Okay, so I asked a little bit earlier when nobody was in the room, how many people were doing Solanus PRP right now? Let's raise hands, let's see. Okay, actually a much smaller group than Agnes and Scarlett. And how many people here just do plain old PRP? More, which is what I expected, yes. So you're going to get a sense this really is next generation, and you'll see why. So, okay, so what we're going to do is I'm going to give a small talk. We're going to bring a panel back up here again. We'll have a live treatment, and then we'll have questions from the audience, kind of like we did this morning, but in this particular category. And for those who, during the lunch break, once again ask me, what about off the face? It's coming, it's coming. So, all right, we're getting there. One at a time. All right. So, the overview of what I'm going to cover, what is this all about? Where can it be used? What's the mechanism of action? What are the benefits? Clinical proof and results. So that's a lot in a short period of time. So let's go back to PRP first, the concept of platelet-rich plasma. And long before it was being used in aesthetics, it was being used for wound healing, oral surgery, orthopedics, ophthalmology, and hair loss. But there has been this rapidly growing body of evidence for use in aesthetic medicine and surgery for rejuvenation and enhanced recovery time. And what I learned over the last 5-6 years is, now we have Solanus PRP, which is a whole different animal, but even PRP itself was somewhat different. And I learned about it because I was doing plain old PRP in my office in Manhattan. I had a girl come in who was a college kid who had some hormonal issues, polycystic ovarian syndrome. I started doing PRP on her. I don't think I used an RF microneedling device. It was probably either microneedling or this Aquagold device, which is a chamber that's kind of like microneedling. And it turned out, unbeknownst to me when she came into the office, her father was a very famous guy at the Hospital for Special Surgery in New York and was the leading PRP guy in the orthopedic arena. And was using it, a lot of famous athletes in their knees and stuff like that. And so through her, I asked to go watch him do this. And he did PRP, and it's a big needle injected into a joint. But it's so different than what we do because he hardly spun the blood down at all, and it looked really red. And I said to him, whoa, that's just not what we do at all, because we want kind of pure stuff. And he said the reality is each field is somewhat different. So in the orthopedic arena, anybody here who's an orthopedic surgeon? Nobody? Okay. What they're trying to do really, what are they trying to do? They're trying to really create a lot of fibrosis. They want a huge inflammatory reaction. And so they want sort of lots of contaminants in there, which is the exact opposite of what we want for scalp or for face. So it's a different world, and we're going to talk about that. So, what's PRP as we historically have known of it? It's plasma, it's platelets, it's this concentration of platelets that is derived from one's own whole blood, and you all know that. And then the platelets are this huge reservoir of bioactive molecules, growth factors, cytokines, all important for angiogenesis, cellular migration, differentiation, and ultimately proliferation of our cells. And so, typically, as it has historically been done over the last 5, almost 10 years, you collect the blood, you put it in the centrifuge, you want to separate the platelets in the plasma, and you extract the PRP component. And there really has been both preclinical and clinical stuff, even on PRP, which still is sort of this gray area. So this is some of the nude mice stuff. If you look at the PRP group on the left there, you can see the thickening of the epidermis and the dermis because of all these growth factors and cytokines in the PRP. And ultimately, this was then translated into treating patients on the face, and generally it is a series of treatments. And PRP was injected however you do it. And you can see this is just classic PRP, facial neck rejuvenation. I know there are some people who do this as a de novo treatment. Most of us have used it following other things we've done because it not only helps create collagen, but it decreases inflammation. So when I talk to patients about doing scarlet most commonly or something like that, I tell them the PRP is going to add to the results because in essence it's a 1 + 1 is 3. The device itself creates new collagen. PRP through a totally different mechanism creates new collagen, and then you're making the recovery time even that much faster. And here you see some of that close-up look at the improved skin tone that we see when standard PRP is used. Histologically, we go from the animal models to the human models, and we've done some of those studies, and you see the same thing. You see an increase in those proliferative epidermal cells, ultimately thickening of the epidermis and dermis, and just a reordering of the skin. and you can see that slow improvement over time that occurs, and the results really last for a while. So where does Solenis PRP come in? Because this is really a whole new area now, and to me this is almost like Agnes RF. It really is revolutionary, it is different, and it's going to change the field. Because it's not just PRP, but it's an autologous volumizer. You're actually creating volume with this, which PRP in itself doesn't do. So it builds on this proven efficacy that allows longer lasting tissue regeneration, and it is a unique process, which we will describe, and a bunch of you were here yesterday for the workshops, that converts the patient's own blood into this gel-like substance, which in itself is sort of a filler, and it supports the dermal infrastructure to volumize the face and even the body, and of course it's derived from the patient's blood, so there's no risk per se of any filler. So it can be used on the face and on the body. It can be used in immune-compromised patients because it's their own, and it's great for some of the more difficult areas. We talked this morning about lip lines. You know, it's just so hard to make that better, and I have always found PRP helps it some, and this does even better. So tear troughs, lip lines, and again, larger volume areas, because in essence, you're injecting PRP and, if you will, a filler at the same time, because that's how it acts. So mechanism of action, you know, it all gets back to starting with PRP, which is this autologous high concentration of platelets in a small volume of plasma. Typically, if you look at this, it's 2 times the amount that you'd see in whole blood, but Solenis PRP takes it to the next step because it uses the specialized collection tube that collects the blood and a custom centrifuge to isolate the platelets, and the goal is to move the highest possible percentage of platelets into the plasma, because that's what you're going to be putting in there, while removing the undesirable components of the whole blood, which you're not going to use, which you might use in orthopedics, but you're not going to use in our field. And so we know what this is doing. You know, you're promoting angiogenesis. There are all kinds of cytokines and growth factors which lead to healthier skin. So Solenis PRP, what does it add to the picture? It's quick, it's simple, it's very predictable, it's easy to use, it's FDA cleared. A lot of the devices out there are not. It's a sterile closed system. It gives you an extremely high concentration of platelets. You get a 90% platelet yield, which allows you to have these high concentrations that we want. It's got something that is really unique to it. It's got this proprietary MNC7. It's an anticoagulant in it, and that actually prevents some of the burning and also lessens some of the bruising that can occur when we do PRP. And it is, of all the technologies out there now, and if you start looking at all these, you know, this is all, what's my ROI, what's it going to cost me? It's the lowest price per cc of PRP, whether you use, and there are 2 versions of this, which I'll get into, whether you use the 22 cc or the 11 cc tube options. So, you know, what's the advantage of this thing? You have this vacuum-filled, internally coated glass tube, which is designed to prevent the platelets from sticking to the edges, which in a typical blood drawing tube is going to happen, so it doesn't happen here. You precisely draw the blood at a pressure that prevents any lysing of the cells, because obviously that's what you want. You don't want to be just drawing this stuff back. As I said, it's got the anticoagulant, which is pretty unique to this, that reduces the acidity while preventing the coagulation of the platelets, which clearly you don't want to have happen. And it delivers the non-activated platelets, which are positioned on the top of the gel. And it also has a patented separator gel in it, in those tubes, and that spares 90% of the platelets above. It leaves essentially close to 100% of the red blood cells below, and it removes 92, 95% of the white blood cells. So all the stuff that orthopedic surgeons may want, we don't, and it gets rid of all this. So this is not to be used for orthopedics. And so what you get is this platelet-poor plasma, so that's PPP, is extracted from the PRP, and the PPP contains 60% albumin and is processed in order to denature the linkages or hydrogen bonds within all these protein molecules. Those proteins are then refined into a more densely organized mesh-like structure. This is the gel, and it lasts about 4 to 6 months, so in essence you're giving people a filler. The structured properties allow for a slow extended release of platelet-derived growth factors. So think of PRP as putting those platelet-derived growth factors in there instantly, and they do their thing and they're kind of done, where this is sort of a slow extended version of this over the course of about 6 months. And what does that do? It does what we want it to do. It induces neocollagenesis, it enhances skin radiance, and revitalization. So as I said, it's sort of PRP on steroids, because you've got all this other stuff going on in a slow release formula. So the science behind this, if you look at this illustration, you've got platelet-poor plasma. It's processed to break those hydrogen bonds, which I talked about, within the plasma molecules. These proteins then unfold, and then they're restructured in a more densely organized mesh-like format, which gives you that gel. So as I said, there are two versions of it. There's 11 cc and 22 cc patient kits, and they're essentially the same. It has to do with the amount of platelets per dose. So from the 11 cc tube, you're going to get roughly 2.5 billion platelets per dose, and the larger tube, which makes sense, you're going to get about 5 billion platelets per dose. So it really depends what you want to do with this. So the benefits of this process, this Solenis Derma PRP, is it serves as a template to guide cell attachment, differentiation, and proliferation. It acts as a carrier for tissue-specific growth factor delivery, and this gel, this new mesh-like structure, provides a bridge for new collagen and new tissue to form over time. So 11 cc, 22 cc tubes, what do you need to do this? Obviously you need a centrifuge. You need the Solenis Derma processing unit to do all this stuff. You need a cooling unit, which actually cools it down. And then you get, as I said, those are the syringes you're going to get, and the PRP and the PPP combined together. So the kit components are the blood collection system. You obviously need to draw that blood, so however most of us do it, typically 18-gauge needles. You need a syringe with Luralox on them, much like you do standard PRP. You need a female Luraloc adapter because you're going to be putting this stuff together. You need that processing module with those PRP tubes, and this is all the stuff that comes with it, and obviously whatever local anesthetic you want to use. So the process by which this works, and we're going to be seeing this, is you harvest the blood like you normally would. You then put it into that tube. You draw out the PPP, right? That's not PRP, the PPP. You place that syringe with a tip cap into the Solenis Derma PRP processing module for about 10 minutes. It heats up, and then you let it cool down. And ultimately, these platelets are then resuspended by inverting them. And you draw out now this revised PRP, if you will, which is really gel-like. You go back and forth between these two different syringes, and ultimately you inject it or wherever else you choose to apply it. There's a lot of literature on this now that has come out. I mean, it's been published in a bunch of different journals. This is one that was used to look at facial volume restoration over time. This is a clinical study using this for the treatment of nasolabial folds. As you can imagine, there's just so many places you can put this. We've started to do some of this for cellulite now. You think about the butt lift, which historically has been done with things like sculpture, radius, those sorts of things. You've got this gel mesh here, which allows us to do much more than PRP. We talked about acne scars and using scarlet for that. This is a study that looked at simply using this process for acne scars, yet in real life. I typically do both together. And here's another one for facial rejuvenation with this autologous dermal filler, which we don't normally think of PRP as being at, but Solenis PRP really is. So this is something very different. In terms of results, here's a before and an after. And we'll go through a series of these, and then ultimately we're going to be treating somebody again before and after. And there's a glow to the skin. The skin looks healthier. It's not really meant to lift the skin. That's what you're doing with Scarlet, or for that matter, Agnes RF. But there's a glow to the skin. The skin just looks healthier. It looks younger. You're taking this patient's growth factors, putting them back into their skin. Before and after, you can see this. Again, Solenis PRP. Here's another example of that. Someone asked this morning about the horizontal lines. I don't find I can ever totally get rid of them, but we can do Agnes RF, Scarlet, in this case, Solenis PRP, and the same thing with scarring. And so, we're sort of presenting these talks in a vacuum. I showed you the results in Scarlet radiofrequency in terms of breaking up a scar. This is Solenis PRP, but in real life, we often do both together. Improving the quality of hands, the hands like the eyes, another sign of aging of the skin, and making them better with this result. So that's it for the Solenis PRP. I think we're now going to start the hands-on session. And with that, I'm going to invite back our panel, smaller panel than this morning. So let's see, a couple of newbies who have not been up here yet. So Peter Helton, I think you're out there somewhere. Where are you? There you go. All right, so he's from Newport Beach, California. Heck of a lot nicer than New Jersey, no doubt about that. And he does cosmetic surgery there. And the other person who was not up here before, let's see, hang on one second, I'll figure this out. Got you up here now. Lee Thornton, where are you? Lee Thornton, there you go. Okay, so Lee Thornton is a plastic surgeon. And we're going to bring you up to the panel now. Welcome. And then some of the people we had before, let's see, Melissa Gibbons, you're here somewhere. Coming, okay. Ann Watwood, there we go. And then there's me, okay. So I think as we get our patients set up to treat, I'm going to go through this panel and ask each of them their thoughts on Solanus PRP, how it's different for them than just using PRP, where you apply it to, sort of where you see the future. So I think you're first, Ann. Do we have microphones up here? We have no microphones. We need some mics?
Actually, should be.
You guys not have mic?
Yeah, we're on it.
Oh, you're all mic'd, okay.
I have one, yeah.
Okay, so that's fine. So let's start with you. So, thoughts about this versus standard PRP, where you're applying it.
So with the standard PRP, I think I use that more with mild tear trough deficit, hyperpigmentation issues, or any area that's softer. If I feel like there's a larger volume deficit or just really poor skin quality, I like the derma because I'm gonna get more of that immediate fill, as well as getting the long-term effects from the PRP in the area.
Your turn.
So I'm using it very similarly to how Ann is using it as well. But one of the other things that we use it for in our practice to standard PRP will be for texture issues. Mm-hmm. We also use it a lot of times when patients have discoloration and we're just trying to thicken up that epidermis so you don't see the purple or the darkness under the eyes. And then we tend to use more of the derma or easy gel when we're trying to not only correct the texture of an area, but also revolumize an area.
So for me, I would almost say that regular traditional PRP is going out of my practice. For the things that I use topically PRP for previously, I'm using XOE and exosomes, and I'm seeing better results, whether I'm driving that into the skin with scarlet or whatever we're doing with topical. With the derma PRP, I've said in several of these sessions, I'm looking for the place that I can't use it because I'm really using it in new places every week as I'm going along with it. I do a lot of oculoplastic surgery. It's one of my favorite things now under the eyelids. I really like it a lot. I use it both for volumizing and then just the rejuvenation characteristics in the face. But yeah, it's every day and every week is expanding as to where and how I can use it.
Well, I would add to that. I think, I'm relatively new in the derma PRP world, and I'm finding that as time goes on, I'm finding more and more places to use it. And to me, in a lot of ways, it's not necessarily a replacement for PRP, but it's an alternative that I use, and she made the point. When I'm looking for larger volume, this sort of gives me that, plus the PRP benefit. So, Peter.
Yeah, so what's great about this is we're all from different practices. We've got totally aesthetic, we've got aesthetic body, we got plastic, and I did it as a dermatological approach. So I tried to do large surface areas, like the preauricular area of the face, the neck, the back of the hands. When they first gave it to me, they said it's a volumizer, and I'm going, well, I need another filler. I mean, there's so many fillers out there to choose from. So you can't really compare it to a filler because, like you said, it's a totally different category like the Agnes. I mean, before the Agnes was invented, you didn't even know you needed it. So then now that we have this volumizer, what the side effect of it is, or even the direct effect is it increases the luminescence of the skin. So not only does it increase the volume, but it increases luminescence. So kind of a voluminescence type filler is what we're getting out of it. And think of it more as a time-released PRP. We all know the benefits of PRP, but now we're time-releasing that over time with the side effect of having additional volume. Now, they've done studies where if you've done 2 treatments within 3 months, that you can get like an 8-month longevity out of it. Okay, well, that's great. My filler is gone in 8 months. But that's not what you're doing. What you're after is the luminescence of the skin and how good the skin looks afterwards.
So I'm going to throw a bizarre one out there, because I mentioned the idea of where to use it elsewhere. And again, I haven't used it that long, but I've done this in 2 people. So who here knows what the hip dip is? Okay. So let me tell you about me and the hip dip, okay? It goes back about 2 years ago. And again, are you giving me a message, Marina? It goes back about 2 years ago. And again, I work in this large private equity 100 office group. The marketing department at Schweiger Dermatology, which is huge, reached out to me 2 years ago and said, there's a TikTok influencer who wants you to treat her hip dip, and she'll give you exposure on TikTok. Will you do it? And as we all know, you never say no, right? So I said yes. I hung up the phone, and then I immediately Googled, what the heck is hip dip? No idea what it is. And so, and what I did was I used Sculpture, whatever else is used. So I've now treated 2 people with this stuff. Because you get this immediate fill. These influencers love this idea of something that's all natural because it's yours. I don't really believe PRP in itself is going to do anything. And so I mentioned the fact that I think there are other things we're going to keep expanding into as time goes on. You know, whether it's, I don't know that it really will work in the dimples of cellulite, but certainly people who have the sagging associated with cellulite. So I think there's a lot of stuff we can expand into. So as we're getting ready here, okay. How about some questions to the panel as we're getting ready for, yes. Okay, we need that microphone over there, please. I know, you've got so much mileage on that Fitbit of his. Go ahead, question.
My question is, when you're injecting in the lower lid, do you have any concerns of embolization like we were concerned with traditional fillers in that area?
So I'll take that one on, and I would say, you know, of course, and anytime we're injecting in the lower lid or anywhere in the body for that matter, you need to be concerned about embolization, you know, anywhere from buttock fat grafting, where, you know, we've seen terrible issues with that, to around the lips, nose, particularly around the alar creases and so forth, and the same within the eyelids. Personally, I use a cannula, a 25 gauge cannula, and I'm going very superficial, immediately subdermal. There is a plexus there. Those vessels are definitely too small to get into with a 25 gauge cannula. So I don't mean to be cavalier or flippant in saying that I'm not so worried about it there, but I'm not so worried about it at that level with that cannula. But you know, look, anything that we're injecting, you need to be worried about an embolization. The other thing I would say in most cases with this, I'm taking the needle to the farthest point that I'm going to place the filler, if you will, and injecting on withdrawal. And as we said yesterday, I think, always keep that needle moving. You know, don't stay in the same place. If you're meeting resistance on your plunger, pull out, you know, do something different. Don't try to, you know, overcome resistance. It may be the thickness of what you're injecting. It may be that you're inside a vessel wall, you know, so just use common sense.
All right, we'll get some more questions. Let's transfer this over now to Dr. Watwood. Let us know what you're thinking, what you're doing over there. And your mic is not on.
Okay.
There we go.
I think it is on. I think we're trying to figure out the angle so that he can see it. It's kind of awkward because we're not up high enough. Sorry, are you going to be able to see it there? No. Okay, yeah, sorry. I was just poking the hole. I wasn't injecting yet. So we're going to do a couple different things to her. I know she's laying flat. She has some mild tear trough deficit and a little bit of texture that we need to improve, so we're definitely going to do under eyes. I'm going to do a little bit here in the preauricular hollow. Go ahead and smile for me. I want to do a little bit right here through this smile line zone in that area, and a little bit in her nasolabial folds. So those were the primary areas when we were doing her analysis ahead of time. Her tear troughs are not that bad, but then I'm not sure if you guys can see at this, it's that slight texture that she has underneath here. So that's part of what I'd really like to address with her. And so same thing, I tend to use a cannula. So I'm going to try to stay out of the way of the camera, so just let me know if I'm getting in that way. Good, ready? You're going to feel a little bit of pressure as I glide across. And so because we're using cannula and we're more of that subdermal, that's what's gonna make it safer and more comfortable for our patients. Sorry, I know a little sting right in here. Ready? Good. You're gonna feel it go. Perfect. So a lot of times, if you guys see me, my finger's gonna be on there. I like to feel as I inject. So as I'm injecting, I'm feeling it come out underneath my finger. So I know that might make a little bit hard for you guys to see. I'll try not to do that in all cases. So I'll inject a line of it, kind of come back, look, see where I need to go again. So sometimes I just go straight to fanning if I can see it, and other times I stop and look. And then I gotta find that little hole. It's always good when they don't bleed, but sometimes it's...
So for the panel members, any comment on her technique?
No, you're
Do you
not.
do it differently? Is it pretty much the same? Who wants to chime in?
On Ann's technique?
Yeah.
I use a 25 1.5 gauge needle typically. That's kind of my go-to for derma. Unless I do the lip lines, the vertical rhytids, I tend to go to the radius needle or the 27 gauge thin-walled needle. You just get a lot less clogs that way. Yesterday we weren't fortunate enough to have those, so we used the 30 gauge, which did work, but it does take a little bit more plunging and also mixing along the way. But I think where you use, where you want to use a cannula, you can. Sometimes in the lateral aspect of the jawline, I will bolus on top of the bone with the needle, and then typically when I get in front of the mandible, I will, in this more inferior part, I will use a cannula as well, just because of vascularity and the risk of occlusion there. So, but most of the time I do tend to use a cannula when using this product, 25 1.5.
Lee, you mentioned using cannulae. So do you use cannulae everywhere or just in the inguinal area?
No, and I'm glad you asked that because I do use a cannula in the lower lids. Sometimes if I'm lazy and I've got the cannula on, I'm using it in some other areas that I'm very comfortable using a needle in. I still use needles with fillers in the nasolabial fold and many places around the face, just using the same common sense principles. And like anything, you really need to know your anatomy, and particularly where the larger, arteries and veins in the face that you can get a cannula or and a needle into. But no, I use both, and when I'm using it kind of as a filler around the face, I tend to do it with the same, needle that I do with a filler. No, I use both of them.
Peter?
Well, cannula is an art, and if you're just using needles, try to increase your artistic ability and move on to cannulas because they're safer and there's more things you can do with them. Not all cannulas are made the same. TSK are sharper, have a smaller lumen, so a little harder to push through a TSK if that's your favorite. The DermaSculpt ones are a little duller, have a larger lumen, so those are a little easier to push through. I mostly use a 22 gauge, 2 3/4 inch DermaSculpt because I'm trying to do large areas of the face. So it's a little intimidating the very first time you use it because it seems like it's so large. But the holes heal within 24 hours and they're imperceptible. I also push it through a 25, very rarely a 27.
I'll keep asking.
I agree with Missy, a 27 gauge needle works well if you're trying to chase the rhytids around the upper lip. So, yeah.
How many people here are using cannulae, whether with fillers or with this?
Okay.
Okay, good number, okay. And how many people use solely needles? Very few. So I'm going to give you, my bias. It's just me. So we were one of the FDA study sites for Allergan's Voluma trial when they actually looked at cannulae, which was the 22 gauge you're talking about. One side of the cheek and the standard needle, I think it was 27 gauge on the other side, looking at clinical results and looking at potential side effects. And so it was an FDA trial because they wanted to get their labeling for cannulae as well as the filler. I will tell you the results are identical. The incidence of ecchymosis, rare on either side, but identical. No thromboembolism anywhere. And so I started way back when there were only needles. I kind of moved over to cannula because I think there is an artistic part to that. And that trial convinced me that do what you want to do what you are comfortable doing. In the end, it's whatever you're good at because either approach is fine. So, Ann, how about you? Are you solely a needle person? Do you use cannulae?
Do I what? Sorry. What was the question?
I I got it right. She was injecting somebody. I said, are you only a needle person, or do you use cannulas sometimes?
No, I'm using a cannula right now. I use cannulas in a lot of
Oh, I didn't
area.
even see that. Okay, you are using cannula.
Yeah, the lip is the one area that I'm mostly needle, but in a lot of other areas, I'm primarily cannula.
Yeah, and I don't think there's a right or wrong. Any questions out there?
So everybody out here probably does lips, if you do fillers at all. One of the unique benefits of this autologous gel filler is that it actually adds redness to the lips. And it plumps the lips in such a way that it's not hyaluronic-like. You know, I get women who are over the age of 50 that are totally fearful of getting their lips done because they don't want to look like them.
That's a look.
That is a look. That is a look. But what this does is it gives you a natural lip. And it is a little swollen for the first day, but through the magic of PRP, 90% of the swelling goes down the next day. And that, you know, the bruising of it is minimal, and it does a great job on the wrinkles of the upper lip. So total peri-oral rejuvenation is an easy way to get started with this product.
To add to your point too, when I first started using Derma, or we tried Derma, I was thinking in my head, because in the past we've done a lot of Easy Gel, and I was thinking that the process was going to be the same. So with Easy Gel, we would bring a patient in every 4 to 6 weeks for about 3 sessions, and that's when they're to their kind of magic spot where they're going to stimulate the most collagen, and that will happen over the course of 90 to 120 days. And so the biggest switch in thinking for me was that Derma was different in the sense that you do not have to inject the patient on that 4 to 6 week schedule multiple times. You can do it one time, or you can add a second subsequent treatment in within that second month and extend the longevity of that fill look part of the product even out further than 6 months to more of that 9 to 12 month mark. But I will say, with some of the other fillers, regenerative fillers, I wasn't getting that 90-day mark where they still look filled. Now the patient would come back and the skin integrity might look different and the color might be improved, but I wasn't seeing the fill part of it. And so the patient would be saying to me, well, the filler part of the Easy Gel is gone, but my texture's better. And so Derma will give more of that filler hold to the tissue longer than some of the other products. So that was a bigger learning curve for me, to not think I had to bring them in every 4 to 6 weeks.
So I focus in on this, this more natural look, and I think it's so true with the upper lips. I mean, I just see these people come in, in my neck of the woods, and I'm sure it's true everywhere, who just have the goofiest looking lips. And it's always a hyaluronic acid, because nobody puts sculpture radius in there. And they just don't get that with this. They get a very natural look to them. So one of the things I want to pose to the panel is, and we'll get your question, I see your arm, I've done PRP now for years, and I'm switching people over to this, and I'm charging more, okay? And so how do you handle the discussion, particularly those people who've had PRP before, how do you handle the discussion about how this is different, and therefore I'm going to charge more for it?
I really look at it as a much less expensive product. Now, they're paying a higher cost up front, but, what are most of you all paying for a tube of your filler? $250 to $400, depending on what it is.
Not in New York.
And and honestly, I'd have to ask my office manager, what's our cost on a 22 mil kit of this? Our cost? About that, I think. Yeah. So we're getting 1 cc of filler for $250 or $400, whatever you're getting for, and charging more. And with this, you're getting 12, 13 cc's of a filler. Not only that, an HA filler may be stimulatory in some ways, and I think that's maybe true in some people, maybe not true in others, depending on age and a multitude of factors. This, in everyone, has these really wonderful physiologic effects. So you're getting that you don't get. And the other thing, when we were talking about kind of alluding to this whole idea of filler face and lips that look abnormal and nasolabial folds that look very, very thick and full and non-mobile, what's amazing to me about this product is I can put 13 cc's in the face and not worry at all, and this is, I really mean this, not worry at all about having an abnormal filler face look. Now, sure, it has to be done artistically, it has to be done carefully. Whereas I've seen people, you know, that have been to places and get 2 or 3 cc's of filler and look awful. So it's amazing that this product is so forgiving. And the other thing,
because it's physiologic.
yes, no question, it really is, and it makes a huge difference. And the other thing about it is, and why I say I'm still trying to figure out where I can't use it, is you can take this one product and I can use a needle and inject intradermally, so for vertical lip lines or anywhere that I have, you know, very, very deep creased superficial rhytids. So I can use it intradermally, like I would maybe 1 tube of filler. I can use it immediately subdermal, like I would with nasolabial folds and so forth. I can use it kind of in deeper fat compartments in the face, or I can use it down around the periosteum. So, you know, with this one product, I can go anywhere on the face. So I think all of us early on, when we were on the phone with this product, kind of brainstorming on it, at first when we had the 22 mil kit and you're getting 12 mils, you're thinking, what am I going to do with 12 mLs of this? And very quickly, within weeks, we were all saying, I could use more, you know, because you really can use it in so many layers and really sculpt with this in a way that you can't with a filler. Sorry to be wordy, but I'm pretty excited about this product. I really like it.
And if you think about the price, if you're bringing a patient in, we charge $1,500 for Easy Gel, and you're asking those patients to come in 3 sessions, so it ends up being $3,500, $4,000. And if you're charging pretty much the same, but you're offering even a longer lasting result, and you're getting 3 times as much, because I don't know of any other product that yields 11 or 12 cc's of usable product. And I think when you talk to patients in that regard, if you show them those syringes and you go, if this was 11 or 12 syringes of filler, I mean, this is, you know, think about the cost on that. So they're very savvy when it comes to that. And I think more than ever, people are very aware of what they're putting in their bodies. And so it's just perfect timing, right? Because everyone now wants to go to this regenerative aesthetics or regenerative medicine model. And so for us that have been preaching to the choir a long time with biostimulators, whether it was Radius or Sculptra and our autologous fat grafting, all those things that stimulate or biomimic, it's the perfect opportunity for you to capitalize on that, and you have a biofiller. And I don't think that they mind they're paying a little bit more, because they end up paying a lot less, because you're not offering just a filler, but you're changing the skin integrity of their skin and doing so much more for the anti-aging process.
Peter.
Yeah, so one of these is equal to probably 3 Sculptras, I would think. So, you know, if you're going to come in and do 3 Sculptras, you can pretty much charge that. I've been still playing with it, so I'm not quite solid on what my pricing is going to be, but I at least charge $1,500 for it. You know, with this, once this voluminescence comes through, and you know people get excited about it, I think they're not going to have any problem wanting to do more. No one's excited about coming in to get their next Sculptra, but I think they're excited about coming in to get their next.
To answer my question, and again, I don't know, everybody charges different prices for PRP. I'm pretty much charging double for this because I do believe it does so much more. I think you get longer lasting results. I mean, I don't, like I said, I add PRP to all the other stuff I do. I think this stuff does something in its own right beyond just PRP. So there was a question over here. If we get the microphone over here.
Right here.
Okay.
So we have had a demonstration of the competitor that she's speaking of, the Easy Gel. It didn't go very well. The block was not well heated enough, and we didn't have a good product at the end in order to inject, that I was comfortable injecting at least. What is the failure rate of the Derma PRP in terms of if it doesn't process well, you can't inject it, it's too clumpy,
So you didn't get the gel. Is that what the issue
it did not
Right.
gelify.
Which I haven't used Easy Gel, but I've heard
It
that.
looked very
Is that PRF?
odd, and I just didn't feel comfortable injecting it. It was very chunky and almost like cottage cheese.
And
Would not have gone through the cannula at all.
So I've not experienced, sorry.
I haven't seen a failure rate, so there's no failure rate with this.
So
Zero.
0?
we've had a,
Is that in writing?
so the only reason there'd be a failure rate in that product, it can be based on somebody's hematocrit health. Because we're dealing with plasma, and has anybody ever donated plasma? And they look at like the color of your plasma, and sometimes it's very cloudy. So the only time we've ever seen anything, we haven't really had it in the U.S., and there was small reports over in Europe that the gel would fail per se, because somebody's poor hematocrit health. Somebody eats a really fatty diet before, or drinks a lot the night before, or something like that, or has a higher fat content in their blood. When you spin it down, it looks a little more foamy and it doesn't quite gel up a lot. It's because plasma does carry.
Your mic's off.
What's that?
You lost your mic for a second.
Oh, plasma does carry some fat in it, so it might foam up and bubble. But typically, you could probably redraw that patient with a smaller kit and still spin it down or heat it a little longer. I'm curious as to a true failure rate. We've never actually seen it in 5 years. So it's been researched since 2018, and then it's been utilized in Europe heavily for 2 years, and here since really March or April. So we haven't really seen that. But we have seen issues in PRP with some patients in general PRP just because of their hematocrit health, so depending.
And
That'd be the only variable.
You can usually tell that when you spin their blood. You immediately can kind of tell if their cholesterol is high. I mean, you can just automatically tell before you ever start the process.
Yeah. That's a good question. Thank you for asking.
Yeah, good question. We got another one. I'm coming right to you.
What's your protocol if there's an occlusion?
I love this one. Okay.
Avoid it.
I have jokingly said from the podium, if that happens, you immediately pee in your pants and call your attorney.
That's right.
Not a very technical answer. So go ahead, if there's an occlusion. And I think she means not an intravascular occlusion, but the more common sort of compression occlusion where you see some blanching, they tell you it hurts. How do you handle that? Because obviously that can occur.
So I would handle it the same way that we would treat an HA or any vascular occlusion or vasospasm. We would do heat. We would do Hylenex, because Hylenex is just going to dissolve the hyaluronic acid in that area, making more space available to vasodilate if necessary. Heat and Hylenex is kind of our go-to. I mean, I guess you could do nitroglycerin, I think, is here nor there now, right?
So I'm not sure I've ever even heard of and I may be wrong on this, forget about this stuff. I'm not sure I've ever heard of a PRP-induced occlusion either.
I never have either. Now, with this product being more gel-like, common sense makes you think that, it could occur. But, I think at this point, I would agree. I would treat it like an HA occlusion. And certainly if you have a vascular occlusion, with vision loss or impending tissue loss, then those patients, unless you can handle this in your office or your clinic, probably need to go to the hospital and have some thrombotic therapy and so forth, heparinized, maybe even acute thrombolytic therapy.
And I think many of us have seen the more typical compression type occlusion, where they they get blanching.
So this product altogether, compared to HA fillers, which I still use and and love, but is more forgiving in that sense completely. And I don't, it's early in the process. I'll be surprised if we see that as an issue with this.
We haven't had one in 3 years.
Yeah.
I'm not surprised.
So they never had one in Europe. I spoke with the medical director actually very recently in Israel from the Star Medical Company. They said in all the studies and in almost 3 years now that they've been utilizing it in Europe, they haven't had a single occlusive event, and we haven't had it here in the United States as well. But it's pretty much kind of the protocol like you talked about. They recommend if it were to happen, saline flushing, massage, and heat.
Because in theory, hyaluronidase is not going to do much for it.
No, not for that. Yeah.
Yeah, so,
But, again, this is a physiologic process where all the fillers are really foreign bodies being injected.
right.
So they are different.
It's important to have a moving needle or a moving delivery device. Larger bore cannulas are safer. Stay away from high-risk areas like the glabella and around the nose.
Yep. We got a question over here.
I did have a quick comment. It has been reported in the literature that PRP into the face and into the scalp for hair has caused ocular occlusion and blindness. So it's not, I can't speak to this, but generalized PRP injections into the scalp and in the face or facial rejuvenation have been reported with for ocular occlusion.
Here we go.
Makes no sense.
Right here.
I have a totally different question. How was the face numbed up? What was used?
We used local, and then I used a little bit of Lido with epi injections at the ports where I was going to create the opening for my canopy. Sorry, buddy. So that's why she has a couple spots that are blanched right where I was putting my ports in.
One thing that I've seen a couple times now are nodules that have come from Sculptra and really being disconcerting because it's been under the eyes or in the cheek area. So this seems like a nice alternative to avoid that because it's been a little messy, you know, with those nodules forming from the Sculptra.
So I'll respond to that first and then listen to what you all have to say. First of all, I don't think sculptures should be injected into tear troughs anyway.
Ever.
For that matter, also upper lips, because that has been reported as a problem. And then once you get them, you're right. I mean, they will eventually go away, but it usually is years. And you're never going to see that with this stuff. So.
Correct. Yeah, you're not going to see that with this, at least persisting.
Ready for my other.
Maybe this is a good time to lead in talking a little bit about viscosity. You know, if any of the AMP guys, you know, give me a signal, I'll stop talking about it. But
go for it.
Serendipitously, when I first used it, I didn't heat the PPP long enough, so it wasn't very gelled. But I was doing this on an employee. For those of you all that were here yesterday, this is redundant. But it was thinner, but as I mentioned, I use a lot around the eyes, and I'm going right under the skin, between the skin and the orbicularis, which, at least in my hands and doing a lot of surgery in that area, is the only area that makes sense to inject. So I like the idea of it being thinner and less clumpy, if you will, or easier to inject and more fluid, which has led to this kind of obsession now with fooling with the time that I'm heating it to get different viscosities, or varying the percentage of the gel PPP you're using versus the very liquid PRP as to what viscosity you want. So you can get very thick and viscous with this or very thin. And you think, well, what's the difference in very thin? We're still unwinding that albumin protein. I think the scaffold is different. When you look at what albumin really does in the blood and carrying vitamins and enzymes and so forth, you know, I look at this as kind of a scaffold for where the PRP is setting up and doing the things that it does. So, you know, you really can vary that viscosity a bit, which helps with clumping, particularly if you're doing intradermal injections or anything very close, right? We don't notice the clumping down deep along the periosteum. It may or may not do it, we don't know. But that's one nice thing, again, about the usefulness of this product, is that you can really vary that viscosity, and I'm finding that very useful in my hands anyway, that I can do that.
Yeah, if you cook it for longer, it can be thicker, but you really don't need to do that. If you just do what the directions say and do it for 10 minutes, you can inject it intradermally. I agree, maybe thinning it out around the eyes. I haven't had enough guts to try that yet.
Yeah,
but,
right.
Monday.
I have two questions in the back, right here. My first question is, do you have a recommendation of patients who are on anticoagulant medication should stop like about 3 days prior to this PPR injection?
I mean, in that sense, I don't treat this any differently than any other filler. I have given this and other fillers into people who are on aspirin who will not come off it, which still boggles my mind because I don't believe that does anything. And they might get more black and blue. It's not going to lessen the response, and if anything, maybe they'll get a little bit less black and blue. But I try to get people off any anticoagulants. I just don't want to look. And most of the people who do this, frankly, are not on anything really significant. I mean, they're not usually taking Eliquis or some of those other things. What do you think, guys?
I don't. If they're on anticoagulants, I've still injected them. I mean, you're injecting platelets, so it's gonna clot. I don't adjust it for any of my fillers.
We had two questions back there. That was one.
The second question is, if patient is sensitive to the epi and the typical lidocaine, could we use the alternative carbocaine or mepivacaine? Because some patients do get heart palpitation.
I think any cane
You do
you
not have
want
to
will
numb the ports. That's just a personal preference, meaning you can use zero lidocaine at all for the ports if they're super sensitive. There's some injectors that never numb ports for cannulas, so it's also completely fine to skip it and just use topical.
I mean, to me, the advantage of lidocaine is it's quick acting, kicks in very quickly, but otherwise they all work.
Yeah. Any cane you want will be
I
fine.
agree. Yeah, I don't think it matters.
Question over here.
Let's get Rob's mic on. What number?
One more little pinch.
7. There you go.
Thank you.
I was just wondering the skin effects of injecting. As when you do fat transfer into the face, you sometimes see the whole face look more luminous, even though you haven't injected fat into the whole face. Is that the same thing you see after this? Does the skin look better all over the whole face?
That's a tricky question because when you're using 22 cc's, you're kind of having the opportunity to inject almost the entire face or most of the face. Similar in the sense that wherever you're placing it, I don't think it's just literally going to stay in there, but that scaffold extends beyond where you've actually placed the product. And so they tend to look better for sure in the areas that have been injected specifically, but even in the overall area, I find that they look better. Similar to, let's say when you do Sculptra in the temples or use a biostimulator in an area, you're gonna get that kind of wash effect in that entire region where you've done the product, or used the product. So you typically see an overall luminosity change. Now, with that being said, if you treat the temples around their mouth, is that gonna look more luminous? And I'm not sure that it would. But if you're globally treating the patient, I do think that those effects extend beyond the actual area that you're using the product just because of the tissue itself.
Now, I had a patient with rosacea that I injected, and it was clear from her before and after photos that her nose became less red, and I didn't inject her red. I didn't inject her nose. I injected her preauricular and her nasolabial folds. So there probably is some stem cell-like effects happening over the entire surface area, certainly wherever the blood flow is going in that area.
Yeah, and I would say don't underestimate that. That's one of the real things that's very, very different about this product that you don't get with a non-autologous filler. I'm a big fan of autologous fat. I started doing fat consistently as a plastic surgery fellow after Sidney Coleman came down and schooled us all at Emory on the benefits of fat. And at that time, nobody was talking about these other benefits. The only other person who was really making headways was Gino Rigatti in Italy, who was injecting for breast cancer reconstruction in patients who had been radiated. And y'all have all seen radiation changes in the skin and what they can do. And it started, changing that tremendously. Basically, I'm seeing the same thing with this product. So my answer would be unequivocally yes. I think I'm seeing an improvement, kind of in that area, globally in that area, if that's not contradictory. But
Perfect.
Yeah.
We got another question over here.
I just wanted to check in with the patient. I know yesterday we had a few of the patients saying that it was burning, even though it's supposed to be physiologic pH. So I just was curious if the patient's feeling any sensation with the injections.
What's going on over there, Dr. Watwood?
How's it been? So are you feeling burning with the product or just the pressure from the cannula? So her main discomfort's from my cannula. So she said when the product goes in, she's not feeling any burning or stinging, but just some of the pressure or the zingers as I'm manipulating cannula in there.
Sure. Yeah, we have a question over here.
I haven't seen it burning in any of my patients, but I do blocks on them all, so.
Yeah, I haven't either, but I think you get that probably that sensation when you're doing an intradermal injection, right? I mean, they hurt more, so it may have been yesterday, whether, I don't know what they were getting, but if they were getting an intradermal injection, then, they're gonna feel that more, just like any kind of intradermal injection. But just in general, I haven't really had that complaint, really, and not a lot with filler either,
Yeah.
so much, with HA fillers.
How long would you wait after either Sculptra or fillers to do something like this at the same tissue level?
I think you can even do them the same day. There's a lot of discussion around even using the 22 ml platelets to hyperdilute if you're using another biostimulator like Sculptra or Radius instead of using saline. Why wouldn't you use that? So I have no problems in our practice. We'll stack it in the same day, or you can even dilute your fillers with, using this product as well. So.
We got another question here.
Yeah, stack them.
Hi. So one of the problems that I encounter in my practice is the temporal area that shows volume loss and subsequently the sagginess of the rest of the face. So is this product can be used for the volumizing of the temporal foci area or subdermal over there?
Yeah, I mean, I've used it there, and frankly, I take the same approach that I use with fillers. I go right down the bone, and I lift everything up, and you've got this gel matrix, and it lifts it right up. Everybody agree?
I totally agree, and again, I'll kind of repeat what I said before, is the cool thing about this product in layering an area like that is you can layer this in multiple layers where you may not with a filler, something other than autologous fat, but you can go deep, you can go kind of in the deep temporal fascia area, if you will, where there's an expandable kind of space there, and then you can go subcutaneous or subdermal. So,
just a lesson in the temporal area. If it's been previously treated with a scarification type filler like Radius or Sculptra, the problem is, there's this, it's solidified and then you have a tube of the vessel. So if you nick through that vessel, any semi-solid that you inject has the potential to go into that vessel. So even though you're not intravascular, just a nick can get you into there. So, be careful whatever you're injecting in the temple if it's a scarified treated area.
Okay, so our patients pretty much, other than a little bit of swelling in a few areas. So we did the tear trough area, we did preauricular hollows, we did smile lines, and we did nasolabial folds. So we covered quite a bit for her. She was thinner back here, so I put almost 2 to 3 cc's on each side, almost in the same way you would do like a Sculptra to help fill that in the skin texture. But I was also able to really go through and fill the product in these smile lines. This is a zone where I really do not like other products. I feel like if you put too much there with an actual volumizer, when they smile, they look like a chipmunk. And, and she's the same as me. We both get this. So I threaded that all the way through here, which is going to improve this overall skin texture, soften nasolabial. So you can see it's, a little bit of swelling, not too bad. But with the cannulas in pretty much all of those areas, lips is the only other area that I really like to use needles. Her downtime won't be that bad, and she looks pretty good right away. All right, any questions about what we did to her as far as...
Any last questions before we switch gears again?
We got one.
Oh, we have a patient question too, but we'll do this first, and then the patient has a question.
You want to go to doctor? Question. We're going question.
2 to 4 weeks. Okay. So she wanted to know how soon she can do a scarlet or heat-based treatment over it, and I usually say about 2 to 4 weeks. I want to let everything settle in, do what it's doing, and then she can go right over it with that. Because she's addicted to scarlet, is what she said. Okay.
Dr. Lei, I have a question whether this product will travel, especially if you inject it probably in the subgala or in the temporal area. Will it travel downward? You know how Voluma travels also? After injection?
Traveling of this product?
Mm-hmm.
I haven't seen that.
I haven't noticed it, just from doing a lot of surgery in that area. There's an area there that's called the superficial layer of the deep temporal fascia, and it's kind of the way you get, from the temporal region down under the zygoma into the face pretty easily. That's the only plane there I can really imagine that this could travel in, and it's what we would call a loose areolar plane. So it has, septi in there. I don't know. It would be
this being
a little
the
bit hard
lattice,
for me.
being that it's albumin in your own tissue, it sits really well very quickly. We haven't seen any travel thus yet in any of the trainings or any of the stuff I've seen in Europe as well. So it's pretty set once it's in there because it bonds with your own tissue so well, because it is your tissue.
All right, final comments, Peter.
Oh, well, so you were talking about competitors. I don't really see a competitor to this product. And, you know, the reason is, you know, the AMP does a good job of bringing the latest technology to the
His magic bag.
to the forefront, right? So it comes in sizes, right? You got a 6 ml size, and you got a 22 ml size. So, you know, you can do a lot of surface area with this sort of thing. And, you know, when I first got into this, it was PPP, PRF, PRG. There's just so many PPs going on. So it's a little hard to conceptualize. But the reason it does so well is because of this gel separator. So all the competitors don't have this gel separator. What this gel separator does is stops the red blood cells from coming into contact with the plasma. Now, the plasma portion of it has the platelets down below, and then it has a few monocytes in there that is actually helpful to propagate the process. Down here, you have over 90% of the lymphocytes, which cause inflammation. You have the red blood cells, which cause inflammation. So if you're using any other PRP device, you're not getting this gel separator. So most of them use like a buffy coat system, which is basically like a layer of oil on top of the red blood cells. And then you got to try to get all those great platelets, but you're going to get contamination. So, you know, like David was saying, with the difference between the orthopods doing this and the way we do it, we're using pure PRP here. And so the top part is the PPP, and the lower part is the PRP. Just, you can see it now.
All right, how about a round of applause for our patient, our provider, and this panel. Terrific. And we're going to have some of you leave the stage. Our next session is what you were asking for before, and that's off the face. So beyond the face, I'm going to have Melissa Gibbons back up here, Dr. Lal. Dr. Watwood, you get to stay. I need the span, the dynamic duo. Okay, they're coming up. And then Kara Greer, where are you? Kara. There you go. Okay, we got everybody up here. All right, so we're going to show case presentations again. And we'll get comments from this group and, again, open it up to all of you for the next 45 minutes or so, plus or minus, until our next break. Okay, good. It's out of your way. Good. Okay, here we go. All right, so we got a belly. Dr. Lal, it's not your belly, but it is your patient. Do we need some microphones up here? Can we get some mics? We got. You're all mic'd? Okay. No, not yet.
No. We need a mic?
No, we
don't need a mic?
It's wireless.
Let's turn it on.
Yeah,
Let's turn his mic on.
Try it on again. What number are you? 9. Number 9. There we go.
Number 9.
Number 9.
Hello. Okay, yeah. So this is a patient that came in. She is about 60 years old, is a surfer in very good shape, and she had some pseudocellulite appearance of skin with some rippling, very little fat, more of that pseudocellulitic appearance. She did not have a diastasis of muscle underneath because if these things are going on, then I'd rather have them get a tummy tuck because I think it's just a better option for them. And so she heard about Agnes, came to me for the Agnes. We did one session. I used the F3 needle with level 9 400. I did perpendicular all the way from the top underneath the rib cage all the way down to the waistline, really just focusing on that central area, not really going out laterally. And then I did one pass of that, and then I did one pass going laterally at a 45-degree angle on the lateral aspects of that abdominal area where the abs are, and that's how it looked.
And do you think that you just got tightening from it, or did you melt some fat too?
I heard a lot of crackling, so I think I melt fat, and I also got some tightening.
Okay. Any comments from the rest of you on this one?
No, it looks like a really good sculpting of the stomach where you've taken, like somebody who's not that bad. Obviously, they're invested in their health, but, there can be difficult areas once we've hit a certain age. and then just made it so it looks that much better. Because on that pre-picture, it's almost underneath the umbilicus. It's like, it looks like a patch is missing. On the other side, it does not appear like that. So, yeah, it looks really good.
Next.
Shannon, that's you.
Oh, this is a patient of mine. She's actually a friend who came in asking for liposuction. And you often get these patients who come in thinking they need liposuction, but you can see from her baseline photo that if I perform liposuction on her legs, it's just going to get worse. So I don't think there were a lot of good options.
It's going to get worse because the rippling would be made worse.
She'd have volume loss and her skin would be looser. So I didn't really have any really good options for patients. When you do lipo them or try to fat transfer them, what you end up doing is creating defects that you'd end up just chasing your tail and just fixing things that are new problems every time you try something, try to fix something. So again, this is when we first got our Scarlett, and I said, I do have this new device. I want you to come to the office and let's try it out and see how it helps you. And at first, we didn't really think it was doing anything. She'd come in after her first treatment. After a while, then she got her second treatment, and we both felt pretty underwhelmed by the results. And then whose party was that?
Jackson's
It was our son's graduation party, and it was a day party, and people were swimming, and we were in my kitchen, and she goes, and she's gorgeous. She's gorgeous, and she had her bathing suit on with the cover up, and she goes, I think it is working. She goes, take a look, and she lifts up her cover up, or pulled down her cover up.
Just in her bikini.
And just bikini and showing off her legs, and I'm like, oh my gosh, so the results are great. We're so happy, and my neighbor's watching us going.
He said, all my life, no woman has ever done that to me.
So this is a great option for patients like this that just have those lumpy, bumpy legs. There's not a lot you can do for them, but the Scarlett really does the trick.
What's interesting too on that, you could even see on her knees how much the skin had lifted.
Right. And I do make sure
that the knees just from that.
You pull up that skin on the knee and Scarlett that skin while you have it pulled up, so you can get all of that surface area, and the patients will be happy.
So here's a scenario where I don't think I would use Agnes because I want to make sure I'm not melting fat at all.
Right. I definitely wouldn't use Agnes here either.
All right, next one.
And to that point, quick question about the body. So we've had that same experience where we'll start with a face, a neck, and then it becomes an arm, and on and on and on. Can you speak to how you might package these body options?
We don't package them. They're separate. Especially for the thighs, it takes forever. And it just takes a long time, so it costs what it costs. If I'm doing procedures on the face, like if I'm doing a Scarlett of a full face, neck, and chest, and there are a couple small areas that need Agnes, I'm not going to really charge. I'm going to just charge the patient for the tip. If I'm doing a full face, neck, and chest, and the patient needs like an Agnes brow lift and Agnes of the lower eyelids, then I'll just charge them separately.
And I sometimes give a 10% discount if they put multiple areas together. There's not a right or wrong to that, but he's right. This is going to take a long time to do. Yeah, question over there.
How long after the treatment do you tell the patients to look for the results?
I'm going to repeat the question because
thank you.
How long after the treatment do you tell the patient they're going to see their results?
I'm telling patients to wait a full 6 weeks. I'm stretching it out because I think the longer there is between treatments, within reason, the more that they're going to see before their next treatment. So I tend to stay away from 3 to 4 weeks and tend to lean more towards 6 weeks.
And we tell them 6 weeks to 3 months because they are going to look better at 3 months. But Larry always says that as well. When you guys are talking about packaging and everything like that. They will get more from their 4th and 5th treatment than they will from their 1st and 2nd, just based on the fact that you've created this healthier skin and now you're hitting that healthier skin and it's responding. So your goal is to really try to get them to commit up front, in which case you could do some kind of packaging to say, if you're gonna go ahead and prepay for the 5 or 6 now, here's what I'm gonna do for you. Because then they're in it instead of just doing 1 or 2 and then being like, well, I didn't get the results I was hoping for. And that's when we go back to the quote sheet and said, yeah, because we said you needed 6, With body, we're apt to sell more because even if they get really good results from 4 and you've got a couple options then, you see them at 6 months for their first enhancement/maintenance treatment, in that area, and then 6 months later for the next one, and you're going to keep boosting it. But it does take a little bit longer, especially if they're older. So our older patients, you know, instead of treating every 4 weeks, we may treat every 6 to 8 because their body's taking longer to get there, and then we tell them it's going to take 6 months before we're really seeing a difference in these areas. But you have no downtime, you're only getting better, and you know, it's treating areas where maybe they don't want surgery.
How many people in the audience are using Scarlett off the face now? Because you really, if you think about it, you so increase your ROI when you start treating off the face, whether it's stomach or thighs or knees or arms. Let's go to the next one.
Quick question. How many passes?
2 to 3 in our office is our normal.
Same.
Yeah, that's why it takes time.
According to Dr. Na, and what I've learned from him from training with him multiple times, is he says you do your first pass and you look for a result, which is erythema and edema. If not satisfactory, you do your second. If still not satisfactory, you do your third. At that point, once you've hit 3 passes, you're at the max result you're going to get. Any more than that's just more trauma, not more results. He said at that point, once you've hit the 3 passes, they don't need more passes, they need more treatments. And so that's where we kind of stop at that 2 to 3 passes, and that should be sufficient to cover that area.
And we've stopped doing multiple passes. We're stacking our energy closer together, so we're doing more overlapping, because based on the technology, 1 pass should be sufficient. You go down to the lowest step that you want to be, and because it's a non-insulated needle, it's going to reorganize that entire architecture of the skin from the deepest part that you've treated to. And so we are doing 1 pass, but we are stacking the energy much closer together than we used to.
Same idea, yeah.
Oh, here we go. We got 2. I'm here. Right here. Here we go.
We do a ton of body scarlet in our office, and I just took a chance and did somebody's cellulite, started doing someone's cellulite. It's worked amazing. After
So when you say cellulite, do you mean the dimpling? Or
well,
the
I think it's like
laxity.
that combo.
The laxity cellulite
yeah.
versus the actual true bands.
Yeah, but it improves it so much that they're like pleased. And I'm just wondering, the doctor was talking about using the F1A on acne scarring and going in and almost creating like a subcision. If you did have true cellulite, could you kind of do that and combo it with scarlet?
So you're talking about breaking up the fibrous bands, right?
Yes.
Yeah, I've done that with the F3A actually, and it works really well. But you could do it with the F1A.
Yeah.
Okay, how about some comments about this belly? Who wants to make comment? I don't know whose patient this is.
I don't know whose patient this is either.
So my only thought about this, I mean, obviously you see the improvement. I probably would have gone, I would have, after I did Scarlet, at some point I probably would have done Agnes on some of that lower part.
I think we would have done both from the beginning. I think we would have Agnesed the lower part.
So, because I think this would benefit from both.
Scarlet over the
Scarlet over the whole area. You're not going to do Agnes over the whole area, but certainly Agnes at the bottom part. So,
Right.
Okay.
And then something that we do in our office is that
the whole paradigm in the past few years has gone. When I trained in plastic surgery, when the term liposculpting came out, a lot of people thought it was like silly. You know, liposuction, you reduce the fat. You don't really sculpt. But the paradigm has changed, and it's really all about sculpting now. So now, instead of taking away all the fat, what you want to do is create an optimal contour of the abdomen, and that includes that line that goes from your xiphoid process down to your umbilicus, and some kind of concavity to the lateral abdomen. And when I have touched up some people who've had some old liposuction, instead of lipoing them again, I have done Agnes in those areas to enhance those features.
So this patient, you know, the typical patient that comes in and says, I've got bad cellulite, fix this. To me, this is mostly not cellulite.
Right.
It's just rippling. And so Scarlet, what they did, 5 treatments, a couple months apart. And this is to, I forgot who asked the question back there. These are a dime a dozen. And so, you know, not to use this device on these people where consistently, you know, whether it's 3 treatments or 5, and it's going to vary, you're going to make them better. And you know, to his point, you know, you may not see results for 6, 8 weeks, something like that. But I don't think this is such a novel, unique response.
This is another one where I would combine, because in the baseline picture, there's a pretty good little saddlebag there. So I think you could use the Agnes to melt the saddlebag, yeah, and then to do scarlet all over it and get a nice result.
So on this one, the patient was actually like 67 years old, and we were doing like the booty lift.
Yeah, which makes sense because you're lifting things up. Okay. All right. I don't know Helen. Oh, Helen's not here. She disappeared. All right, so this is a New York patient, so I guess I'm supposed to respond, right, because she's practicing New York. And so you see baseline, you see 5 months after a single Agnes and scarlet, and I just think it makes the point. You know, you've got the scarlet, which is giving you the tightening, treating broad areas. You've got the Agnes focusing on the small amount of fat there, and I mean, this is truly sculpting. This is what this is doing. So, any other comments on this from our panel? No. Any questions back there? No. Okay, this is interesting.
Wow. So I did. Yes. So I did Agnes to reduce the volume in the back area, and then I did scarlet to lift. And that was actually the same patient. She's older, you know, in her late 60s, and we did just the one Agnes and 3 scarlet follow-ups.
Was she like a weight loss patient or just age?
That's just aging, yeah.
It's a pretty impressive result.
Yeah, it's a great result. It's just, I'm looking at
I don't know that I would have thought I've done that well, so that's great, yeah. Okay, next. Hands, okay, we haven't talked about hands. Let's talk about hands. Kara?
That was actually just one scarlet, and that was about 4 weeks post-treatment, but she was probably about 40, and it just like smoothed her hands out, like, you know, it kind of just strengthened the skin to keep the veins flatter.
How do you go about avoiding those veins?
Pardon me?
How do you go about avoiding the veins?
I think I just did right around 1 millimeter.
Okay, so not that deep.
Yeah. And I treated the whole hand.
Yeah, I mean, look at that.
It didn't. No, it doesn't puncture the veins. I mean, there's pinpoint bleeding, but it's.
Another way I've done this is, one, I stretch the skin, and 2, I try to move the skin away from the veins. You know, because I think even at 1 millimeter, you might hit some of those deep vessels, and not that it's going to harm anything, but again, trying to avoid the echinosis. So that's a great result. Okay, back
That's
to Vegas
us.
again.
Is that us?
Yeah. Is that me? Just kidding.
It's one of you. I can't tell you which one it is.
This is another one where I think you've really been focusing on reducing the fat volume and then scarleting over the top.
Yeah. Oh, yes. Now I remember.
There
I'm
you
thinking,
go.
I don't remember this patient. Yeah, this is a patient who's she's actually a fitness competitor, but she's also a massive weight loss patient. So she's in great shape, but she does have some loose skin, and she just wanted to get her skin tightened. I also treated her abdomen, which I don't know if those photos, they might be in here as well. But this is after one scarlet treatment, and she's so happy. And since then, she's got her second, so we've got to get those photos. But this is a modality that, and when patients came to you before like this, there really wasn't a lot to do with them. I have a body type machine in the office, which I don't really use that much because the results are just so unpredictable. I have some patients where I treat them with the body type and they're like a grand slam, and then other patients where it looks like I didn't even do anything. And so you end up with unhappy patients, and
I think the next patient.
yeah, it might be the next patient that, yeah, it's this guy. That you end up with patients who are unhappy, who you end up having to give free, procedures to, and it just ends up being a big headache. So this is a nice, predictable result from a machine that, even if I had to do something free for somebody, like a free scarlet to help tighten things up, I'm really paying for just with time and a handpiece. That's not expensive. So I think it's a great tool to have in the office as an adjunct to surgery even. This is the patient I was telling you about, he's like a self-described big kid. He was always kind of heavy when he was younger, came in and wanted body tight. And I did a body tight on him, and it just, nothing happened. And the liposuction part, where you suck out the dead fat and fluid at the end, made his skin even looser. So I body tighted him probably a total of 3 times over the course of probably a year and a half, and really nothing happened. And he was unhappy, I was unhappy, and then we got the Scarlett machine. I said, let me try this machine on you. Scarlett and the Agnes, I said, let me try this machine on you, and let's see what kind of results we get. And this is after 1 treatment. After 3 body tights with very little results, this is after 1 treatment with Scarlett and Agnes, and since then he's had 2 more, so we should get his new photos up here, and it's phenomenal.
So I'm not really surprised by this. I mean, if you look at body tight, and for that matter, Thermi is pretty similar, okay? You know, in theory, they both melt fat and they tighten skin, but I think they do a much better job at melting fat and tightening skin. Then you end up with this laxity that sometimes is even worse.
Right.
Where here, you're really helping that, so. Okay, and it makes sense. So you've got the Agnes, which is going to help on the fat, and the Scarlett, which helps on the tightening. Scarlett knows what that is.
So I know it's a bra fat. It's on the side. This is actually
I have no idea what we're looking at.
I know.
What are we looking at?
It's kind of funny at first because you're like, what is that? So the top is the before and the bottom is the after, and once you realize it's the side boob that's right there, it's that same thing. It's that little chunk of fat. This was actually done by an office that trained with us and had the procedures at our office. But really, this is where women hate when their bra is there and it either pushes it above or below and they feel like they have that second piece. 1 treatment. So one of the things that we've noticed in our practice is anytime we're treating the nice fluffy sub-Q fat that's on the body, whether it's that posterior bra fat or the anterior bra fat, a lot of times they respond with a single treatment. That's not what I expected when I started in the beginning with this. I was assuming the body was going to need more, but we've kind of been surprised that with a single one, you can completely smooth an area. Yes, they may need more skin tightening with Scarlett's, but a lot of times they only need 1 Agnes.
When they gave me these slides to look at last week, I remember looking at this and saying, awesome result, but what is that? So at least now I understand.
Their arm lifted,
right.
yes.
All right, back to questions. Any questions out there? Yes, we need a microphone, please.
Yes.
Hold on 1 second, we're getting you the microphone. He's running as fast as he can.
So I actually have 2 questions. One, when you were talking about doing the 1 pass with just more of an aggressive overlap, what is the overlap percentage that you're utilizing? And then are you in mode 3 or mode 2 on Scarlett?
So it depends on what area that you're treating. So it doesn't matter which if you're doing 1, 2, or 3, because it depends on if you're treating the lower face, or let's say the neck or the abdomen.
On the body area.
On the body, we use 3, and then depending on what we're trying to do there, whether it's texture or whether we're trying to, lift the tissue, you would choose your depth and the energy level based on that. And so I would say probably about a 50% overlap is fair.
What is your normal overlap then when you're not if you are doing 2 passes, are you lower than the 50%?
We typically don't do more than 1 pass, and we just keep it overlapped like at least 50%.
Okay, and then my second question is, we just had an employee who went to CSU for the new Elite device, and they said that they're seeing a lot of combination of Cool Sculpting Elite with Scarlett. Do you guys have any practice with that or results, and what is your recommendation for that?
We do a lot of combination with Cool Sculpting Elite and Scarlett, and typically we allow them to get to, we give them about 90 days because that fat does take about anything really. The general consensus is 90 days to stimulate collagen, 90 days to see results in Cool Sculpting, kind of that same trend, I guess, anywhere. But so we will give them 90 days for that fat reduction, and then we would bring them back in to do the Scarlett because you're going to get a little bit of tissue retraction from the Cool Sculpting Elite. I think with that one more than some of the older technology. So we would let that retraction occur first, and then we assess and would Scarlett them at that point.
Okay, another belly.
This is us again.
Me again?
Yeah, this is our PR woman.
Oh, and this, again, just Scarlett Scarlet treatment, a patient who's unhappy with the laxity of skin in her stomach, and she just didn't want a tummy tuck. I mean, for a patient like this, especially if you can't see under her shirt on the left side, she actually has even more skin laxity above that shirt line. She'd actually be a great tummy tuck patient, but she just didn't want surgery. And so for these patients, they obviously have to know they're not going to get a surgical result, but after 2 Scarlet treatments, that's pretty good without having to undergo the knife, general anesthesia, all that time off from work. It's again something that you can always turn to when surgery is not an option.
So my comment on this is great tightening. My only criticism is, because you've tightened the skin and lifted up that tattoo, you've made an ugly tattoo more obvious. Otherwise, great result. That tattoo looks hideous. Okay.
But I mean, now we
and
can
it's all your fault.
We can send her to our esthetician, and she can get her tattoo removed now.
We can't scarlet away bad decisions.
No, you can't scarlet away. It's not going to work on tattoos. Okay, good. All right.
So this is actually my patient. We do a lot of skin laxity on bodies. Arms is a very popular place. When we started treating with scarlet, we were not doing 360 treatments, but now on arms, most of the time our protocol would be to treat the patient 360 degrees around the arm, and you will get a ton of tissue retraction, and the skin integrity does change. And so this is just 3 months post her 5th scarlet treatment, and this is a patient who wouldn't wear short sleeve or sleeveless shirts because she just felt like she had too much laxity, and she called them her bat wings. So those did improve after scarlet.
So my comment about this is, if you think about it, outside of surgery, which is not an option because that scar is hideous, there's really nothing that works on this. And I would argue that the results for upper arms like this are even better than for legs because you don't have the degree of gravity.
Yes.
And this is really a winner for this area, of which 30 plus years of doing this, I've had no way to treat this. So.
Not only here, but a lot of patients ask me about creepier skin on their arms, and does that crepe erase work? And so it's been so nice to have something to offer them that actually does work for the first time ever.
Yep. And on that note,
this is actually Missy's photo.
Yeah, this is actually our patient. So we did on her, I think she had Agnes and scarlet in her upper knees. This was when we first started doing the body treatments a couple of years ago. But we treated her with Agnes above the knees to lift, and then we did scarlet as well on the front thighs, kind of vectoring as it was spoken about earlier. And I think she got a pretty nice result. Again, knees are very hard to treat, and there's really not a lot of options. So.
And so my only addition to this, and it's interesting, is I would have, when I approached her initially, I would have done scarlet and probably also Agnes on those medial fat pads. You've made the medial fat pads less obvious just by tightening the skin, which is an interesting observation. So.
Well, and there's the surgical option for this is going to leave the patient with a big scar, correct, Dr. Span? Because the only way to truly get the thigh lift is to be from knee to groin with a scar. Right. And you take somebody whose legs aren't that bad and then put a scar in there and it's almost worse, versus look at the amount of result they got with a very minimal downtime procedure.
Right, and you're also not going to get it, even if you do a medial thigh lift, that lateral part of the knee, you're really, the action's not, it's just too far away from the incision to really have a lot of action on those lateral.
And then up with a huge scar, it doesn't work well, and it drops down anyway after a couple of days.
Right.
So, all right, another belly.
So again, patient just had some laxity in her upper abdomen, so we did 3 scarlet treatments. This is 3 months post her 3rd treatment. And again, it kind of opened the belly button up and just smoothed out the upper abdomen.
I think it's a good example of how that younger, healthier skin is always going to get a better result. This is a home run. Some of the others are more doubles and triples because their starting point was worse. But this is great. Another knee.
Again, we do a lot of knees. So this is just scarlet above the knee. We did some vectoring. And to treat the knee, you kind of have to not just treat the knee, but you end up treating a large part of the front of the thigh. And even though it takes a little bit of time, we do have 2 scarlets. Sometimes we double team them to make it go faster. But when you do body patients like this, they will almost always come back for a subsequent treatment on another body part. And so to the point of, do you give them a discount? Well, maybe we do a little bit, but they're not coming to us because they want a discount. They're coming to us because we provided excellent results with a non-surgical option in another area of their body.
And I have treated and taught the use of sculpture in this area, and most recently, the hot topic is hyperdilute radius. they don't work. I mean, they just don't, not here. And so this is a great result. So 3 scarlet treatments, and I think it's pretty consistent with what we all see. Okay, so.
Oh yeah, this is my patient from earlier today. So this is that neck tacking that we did earlier. So of course this is taken.
Anybody recognize her? That was the other Anna.
This is taken with my, phone in the hotel lobby and trying to pair the pictures together. But even with that, look at the difference in that submental laxity and the shape of her jawline. And I was telling them I wish you guys could have seen her when I took her out into the lobby and had her look in the mirror and see her. She was so excited. She's like, I did not have a jawline before, and look at my jawline now. And that's even with some swelling going on there. You can see the difference in the definition that she's going to have and the difference in her submental area.
And yet this is going to continue to improve with time as she puts down new collagen.
Oh, yes.
So
yes.
This is you saw it live. This is pretty consistent with what we all see, and it's a great result.
Yeah.
All right, so before we go to break, do you have that microphone back there? Do we have some questions? Somebody's got their arm up somewhere. Good. Or you're just faster. Look at that. Look how fast he runs.
You can barely see him.
So my question is, ooh, it's loud. For you guys on the panel, have any of you used any of the competitors, the other radiofrequency microneedling devices? And if you have, can you speak to the scarlet with regard to a non-responding patient? I've used...
So you had a non-responder, is that what you're saying? Like
yes, someone who you have used the scarlet on and you don't get the results you were expecting and really don't get great results at all. Do you see that? Have you seen that? Because some of your results after doing radiofrequency microneedling for the last couple of years, I've had a couple of patients who didn't respond, didn't get good results. And I'm kind of blown away. I keep seeing your pictures and...
So I think before we respond, just generically, okay, remember, results are not necessarily cookie cutter, look at the parameters. Everybody's a little bit different, and there's always going to be a certain amount of that. And also, there's always going to be, like anything else, it's always a bell-shaped curve. And so, I've never seen anybody not respond. I mean, I think the arguments for scarlet versus, what have I done? I've done Candela's Profound. It works. It's extraordinarily painful. I mean, it's god-awful. Morpheus, say it again, it's an RF microneedling. It's obviously going to do something. You tend to get a lot more swelling. But I think the question is, if you've done RF microneedling with some other device, they didn't respond, would you treat them with scarlet? Would you expect it to be a better result? And great question.
I just wanted to say before that is just to your comment, everybody's different, right? So we have patients that are, like I said, grand slam home runs, and then you have patients that are base hits, and then you have patients that are strikeouts. And everybody's so different, their genetics are different, how they respond is different, and that's just the way it is. I mean, I would encourage you you probably already do, but just make sure you take really good pictures, really high quality pictures, because a lot of times patients will say, I don't see anything, and then when you really look, you can see improvements. Were they as much improvement as you had hoped? Well, no. I mean, I have a patient last week who, in my eyes, I'm just not really that happy with her after her third treatment with scarlet. But we put the two pictures together. I'm like, you know what? There's an improvement here. And she was like happy. And she signed up for her maintenance, scarlet for 6 months from then. And I was thinking, she's not going to want to sign up. Her results are minimal to moderate at best. But so just make sure you keep those good photographs, because when you pull the new ones up, you'll often see improvement.
So I find my more common scenario is not that someone, quote unquote, doesn't respond at all. Again, it's going to be varying. Which is why pictures are so important. My more common scenario is they are better, but they're still not happy, okay? And then how to handle that person. And we all handle it differently. I don't think it's a right or wrong, but what I end up doing is I will then give them a free treatment after I've shown them the pictures, and I will have them, it's the legal part, I will have them sign a release. It's free, but I didn't do anything wrong, you got results, and this is what it is.
And one more thing, in patients, because a lot of I do think this is a superior device to any of the other RF microneedling that we've had in the past, and we are seeing superior results. But I also am really selective with my patients, first of all, and second of all, I want to talk about everything. This is not a magic wand. So if you're going to go home and drink 2 liters of soda a day, we're not going to get the results that we need, and that's on you, not on me. And so let's talk about optimizing nutrition. Let's talk about hydration, vitamins, sleeping. You know, I had
exercise.
I had a woman last week who told me that she eats stress for breakfast and she just doesn't need sleep and she sleeps 2 hours a night. Wrong. You know, and we'll talk about her tomorrow in the hair loss conversation, but the fact is...
She lost all her hair.
Yeah, seriously. But when you really get into these patients' personal care habits, you can understand why they're non-responders. And so it's really an important part of your history.
Right. And the other thing is, when people clearly want surgical results, these are not the devices for them. Or they're just, you're a facelift. You have a turkey gobbler neck. This is not going to do it for you. You need surgery. That's it. And you got to let them know.
I mean, I typically, you know, when I see patients, whether it's facial or non-facial, you know, I describe that nothing in life is perfect, nothing's a 10. If surgery is a 9 with its issues, to me this is more like a 7, but without any of the issues. That's how I describe it, so, because you create realistic expectations. Any other questions? We see somebody waving.
There we go.
Can you make comment on what we observe on the picture when you did is it the scarlet? Yeah, on the hands? Because we notice also beside the rejuvenation of the skin, the veins are also smaller. And it seems like it's disappearing.
So think about why that's happening, because it's really having no impact on the veins. Okay, so they look better for really 2 reasons. One is that skin is better stretched over those veins. And 2, I mean, what are you doing? You're inducing new collagen formation. So that dermis actually is getting thicker. And you can say the same thing about décolletage. And so the veins are less obvious because the skin itself actually is thicker than it was before.
To me, this is a really exciting spot to potentially add in the Solenis. Maybe do a scarlet treatment, then add in Solenis. My mom has a way of just saying just the thing to really get under your skin.
That's what moms are for.
Oh, mine's the best. My mom, no, I don't do that. Not to my kids.
Yeah.
No, but my mom says to me, "Oh, honey, your hands look like you're working so hard." Which, thanks, Mom. I am working so hard. So, you know, I love the idea of stimulating that neocollagenesis by doing something like scarlet and then coming in with Solenis just to give that pop so that my mom will.
Just remember, we have families to bring us back down to
Is that what it is?
That's correct.
Honey, you're getting those little tits on your back. That was another one. Thanks, Mom.
We got a question over here. Yes.
So I really wanted to piggyback off the person who made the comment about not having any improvement with her scarlet therapy. I guess I needed to know, what did you not see? Because if you didn't see the laxity improvement, did you see the texture and the improvement of the skin coloration? Because I've been using it for over a year and I have never had not one person respond to any of those 3.
That's for you.
That's
You are now on the panel with us.
And do they go home with the good skin line? Or do you, okay.
Are on medical grade skincare. They don't smoke. Some improvement. Some. Not as great on texture with the other radiofrequency microneedling device.
So
and I usually give...
There is a difference with different devices, so that might be the thing too. If you're asking that, do other RF microneedling devices give out different results? Absolutely. Before Scarlett came into our office, we had another one. And of course, like my first instinct was kick the rep out because I already hated the one that I had. And long story short, we bought the Scarlett and gave the other one back that we had for free because we were having so many complications with it. It wasn't working. And it's one of those things where you had all the settings to choose, and radio frequency works with tissue based on tissue impedance. Dr. Nam makes it easy. It's setting 1, 2, or 3, so those milliseconds are primed in for either scalp, face, or body, for how long it has to be on, as well as the power, so it's not like guessing where you need to be. Some of these other devices going up to 400, 500, 600, 700 milliseconds, you do not need to be there for face. And actually your risk with that is lipoatrophy. and as well as body, then you have to get that temperature on for a certain amount of time and keep it there. So if you're using face settings on a body, it's not going to be on for long enough because the tissue is dehydrated and then it doesn't respond. So when it ended up being something that was super easy, where the settings were already built into us for the tissue, because besides being a dermatologist, he has a PhD in anatomy. And then the other thing I throw out there is using the detox ahead of time actually improves your hyaluronic acid production in your skin, which will hydrate the skin, and then the patient will respond better to radiofrequency with more hydrated skin.
Actually, I want to just share the story of how we got here. So you went to Dallas Rhinoplasty and saw Sunil Chilakuri talk, who I know very well. We've been on lots of panels together over the years. And so Marvin came home and said, I think we need to get this new RF microneedling, this Agnes and Scarlet. And I said, no. I said, we have microneedle radiofrequency. It's painful. The results are mediocre. At that point, we had an in-mode device that we were somewhat okay with. But he said, but, you know, Dr. Chilakuri's pretty compelling. And so I called him, and I said, Sunil, I don't want to spend this money on another microneedle RF device. And he said, Candace, you don't have this microneedle RF device. This is really next level. This is taking us into the future. And I can honestly say that results that we've had here are unlike anything that we've seen before.
And Sunil is the real deal.
Yeah.
Yep.
You know, a lot of times you don't realize how great a results you're having until you actually go back and review your photos. Review your photos so you can really see.
You don't remember.
Yeah, you don't remember. You know, the patients don't remember. You don't remember because you haven't seen the patient for 3 months. Then you pull up the photos and you're like, oh, wow. You pull up the photos going, oh, man, I hope when I pull up this photo for there's a result. And then you pull them up and it's right before your eyes.
Try to standardize your photos. I know this is something that you all know, but I really hate to see one photo that's, you know, dark and poorly lit, and then the next one that's super washed out.
Or from different angles.
Or from different angles. I actually saw a study years ago where they showed a before and after that was really dramatic, and the only thing that changed from the before to after was the lighting.
Yeah.
And so it really does make a difference. So try to standardize your photos.
Which is easier said than done.
It is.
Yeah, you either have to take them all yourself or really train your staff to take good photos.
Yeah.
So I was one of the first to ever buy a Scarlet, and at the same time I had a chance to try out the Morpheus as well. And so I did one arm Scarlet, one arm Morpheus, and there was a significant difference a month later afterwards, and now even 4 or 5 years later, you can come up to me and pinch both arms, and my arm that I did the Scarlet is twice as thick. The tissue is twice as thick as what the Morpheus side was. So feel free to come up and touch me. And
Now that's something to look forward to. That's why we're about to give you a 15-minute break. So you can pinch his arm. Question.
Go ahead, Tanner. Yeah, Tanner. Yep, go for it.
Switching gears a little bit.
Come on.
Do you have a protocol for patients that are on blood thinners for Agnes?
Okay, yeah, so we talked about that.
No, not necessarily. I mean, number one, if they are on a blood thinner from a previous clot, stroke, anything like that, I'm not having them get off of it at all. Number two, I make sure their cardiologist or primary care or whoever is managing them is aware that they are going to get a treatment that requires needles to be poked into their skin and that they are cleared for that. And then, of course, I'm going to use the epi if they tolerate it so that I can constrict as much as possible. And finally, Scarlet post-Agnes coagulates vessels and helps to reduce bruising. So then that going over the area is going to help to minimize that. But if it's one of those where they're like, I'm taking a baby aspirin daily because I think it will help, well then get off of it for a week. But if they really need it from, you know, previous cardiac risk, I don't remove it. I make sure their physician knows, and I do my best to let them understand that there's a good chance they'll be bruised for longer.
I always say to patients, and this is true no matter what I'm doing, biopsies, excisions, whatever, if they've had a previous event, I always say, I can stop bleeding, I can take care of bruising, I can't stop you from having a stroke. So I would rather I almost always follow Agnes with Scarlet anyway. In fact, I always follow Agnes with Scarlet anyway. But I just, we have the Neo Elite or we have IPL or something like that to help to deal with bruising, but I'm not about to take any kind of risks. I grew up in Las Vegas. I know better than to gamble.
How do you respond to that? Go ahead.
Can you please comment on the settings that you are all using for body laxity, like thighs, abdomen, arms, with Agnes?
With Agnes, okay.
Agnes or
No,
Scarlet?
Scarlet.
Scarlet.
Because that's a big area to treat with Agnes.
Yeah, it's too large of surface areas to treat with Agnes.
What about fat removal?
So, F3A is great for the body. A lot of times we're doing Power 10 and 450 milliseconds for that, but if I use an F1A in an area for fat, then I'm doing Power 9 and 400 milliseconds. So it just depends on if I'm choosing the F3A or the F1A for the area.
And for the body, I tend to choose the F3A, and then I use that setting that I learned with Dr. Watwood, that when with the 3 needles using Power 9 and
10 and 450.
10 and 450 instead of the 9 and 400.
Yeah, you get good pops.
Right.
When we were talking about bruising, does the panel have any comment regarding arnica?
Everybody uses it.
I don't think arnica does a whole lot by itself, but I will tell you that there's a product that I like. I don't have a financial disclosure. It's not a CME talk anyway, but there's something that I like that's called Collagen that combines arnica, pineapple, bromelain, rutin, vitamin C, and among other things. And I do find that that's maybe a little bit more helpful.
Bottom line is none of it hurts. So,
right.
Yeah.
We use Heal MD, and I really like the CBD arnica component that's combined in that product. So, and we also use infrared LED after a treatment. That tends to really help inflammation and bruising as well. So we just pair that, and so anytime someone's had scarlet Agnes or pretty much any treatment in our office, from filler to whatever, we either sit them under the Pro panel, or if it's a bigger bruise or one of those hematoma type situations, then we actually do the touch with the light stim, because there are studies that show when you actually touch the tissue, it provides a more inflammatory response and helps with the bruising because of the vasodilation of the lymphatic system. So.
All right, I think we're going to take a break at this
No,
point.
one more question.
One more question.
One more.
Thank you.
One more.
Last question, I promise. For the abdomen Agnes treatments that you described earlier, was that a single pulse or double pulse or triple pulse on the F3A?
Mine was single perpendicular and then one at a 45-degree angle going laterally, so 2 pulses per site, per area.
And that was at the 9 and 400?
Mm-hmm.
Okay, thank you.
What about temporal wasting? Would you use Selenus derma, and would you wait before you do,
we talked about derma
afterward?
before. Derma's great for that because it lifts everything up.
Because a lot of time temporal wasting, we have a lot of like enlarged veins. So would you do the Selenus derma first before doing?
Or why not do both?
Scarlet?
Scarlet the same day and do the Selenus derma right after, and then bring them back 4 weeks later for their next scarlet. Because they're going to need more than one treatment if they're very vascular in that area. But doing the 2 as a combination is going to get you more than doing one on its own. So ideally, scarlet right after, immediately Selenus derma.
All right, so the job of a moderator is to make everybody unhappy. We have to take a break for 15 minutes. Melissa's going to come back for the DNA of ROI.